Robert Cohn is a professor of psychiatry at one of our neighbors south of here at Brown University. I actually have not met Dr. Cohn before today. We were introduced by a colleague of both of ours that knew of our interest in discussing this topic today of apathy. And it turns out that Dr. Cohn is an expert on apathy in general. He sees a large number of patients. He's a psychiatrist who sees many individuals, including some patients with Parkinson's as well, but he has a broader concept of what apathy is all about. He's director of the Brown University Geriatric Psychiatry Fellowship Program at Brown University, and has qualifications, I'll mention, in both geriatric psychiatry as well as psychosomatic medicine. And psychosomatics does have a lot to do with what we're going to talk about today. His research is in psychiatric epidemiology, which means studying populations of individuals and the distribution and incidence and prevalence of various psychiatric disorders across different populations, both in this country as well as internationally. And then, as I mentioned, a particular interest in apathy, which he will share with us today. Dr. Cohn.
Good morning. I'll try not to be apathetic when I'm presenting. If I am, don't throw tomatoes at me. So anyways, we're going to talk about apathy in Parkinson's disease. This is actually a relatively new topic for me. I know a lot about it actually from Alzheimer's disease. And so I've learned a lot in preparing this. As you just heard this morning by Dr. Tarsi, and I'm sure you all know, that Parkinson's disease contains motor symptoms, which are your bradykinesia, your rigidity, the tremor, and the postural instability, the blood pressure falling, and when you stand up and you get unsteady, and non-motor symptoms. And okay, I can actually speak louder without a microphone. All right, I'm going to speak nice and loud, and sorry about. So, anyways, the non-motor symptoms consist of cognitive impairment, sleep disturbance, depression, anxiety, fatigue, and the topic we're going to talk about today, apathy. So what is apathy? You just saw a brief definition of it a few minutes ago. And it basically consists of three things. Apathy is characterized by a dulled emotional tone associated with detachment or indifference. The apathetic individual is often described as a bump on the log, just doesn't want to do anything. Okay, or having loss of motivation, interest, or concern. There is a reduced emotional responsiveness to positive and negative events. So some of the other things that may be associated with apathy, well, first of all, as the topic of this morning is psychological and behavioral problems. So apathy is a behavioral problem. You have loss of interest, which we kind of mentioned earlier, loss of pleasure, diminished motivation, and it's more of an effort to do things. You have a feeling, they appear to have indifference, and as mentioned, a flat or masked affect. So, however, also as Dr. Tarsi mentioned, this is not necessarily depression. It sounds like depression, but as you'll see, it is independent of depression. Okay. So, some of the problems that apathy creates is that there's an impairment in attention. People have difficulty making decisions. their decision-making is slowed. It's not as rapid as we normally would have. There is increased risk of cognitive problems, as was mentioned also already this morning, increased risk of depression, and individuals may or may not have insight into that they have apathy. Now, I'm not going to go into this, but this is just kind of to illustrate a point that this is a topic that really has kind of emerged into literature over primarily the last 3 to 4 years. And there's been an attempt to develop criteria for research so that they can distinguish apathy, for example, from depression in Parkinson's disease, as well as in other situations. Oh, wait a minute. Sorry about that. So what I wanted to do is go over one of my patients that I have in clinic and use that patient now, or that individual, I should say, with Parkinson's disease as an illustration of apathy. Since I'm a psychiatrist, I'm going to talk about a psychiatric patient in my clinic. So, this is a 72-year-old gentleman, and he lives at home with his wife. Now, he has motor symptoms of Parkinson's disease that continue to persist despite treatment. He has severe rigidity. He's actually wheelchair-bound due to his Parkinson's disease. He has severe tremors of his hands, and he has a masked face. He is slow in his movements, and his speech is very slow and sometimes hard to understand or hear. However, in 2010, this is many years after he had developed Parkinson's, I met him in 2008 for the first time. He already had Parkinson's disease back then and had it for many years. But in 2010, in reviewing my notes the other day, I noticed that that was the first time I wrote down that he had apathy. And one of the things I noted is that was also the first time he was telling me, when I asked him how he was doing, he'd just say, "I am so-so." He just kind of was indifferent about things. He also, his wife, and reported that he had lack of motivation. He would only watch TV, pray all the time, hold his rosary, or just stay in bed. He had reduced emotional responsiveness. Now, his wife is a character, okay, who was also my patient for many, many years before I ever met him. And she has bipolar disorder, and at baseline is kind of a loud, intrusive person who keeps asking me one question after another, you know, walks up to my table to look what's on there, you know, and then walks back, you know, and she's always interrupting him when he's in the office, and she can be kind of annoying, to say the least. So, however, he doesn't do much about it. He just sits there, listens to her. Sometimes if it gets a little out of hand, he might just say to his wife, you know, "Maria, that's, you know, just, you know, it's enough, that's all." And kind of quietly, but otherwise, it doesn't bother him. You know, she can be as annoying as she wants, and it's all right for him. You don't see him getting upset by it or anything. So, now, apathy is not limited to Parkinson's disease. As a matter of fact, where I learned about apathy is Alzheimer's disease. I actually see lots of people with apathy in Alzheimer's disease, and I treat a lot of people who have apathy. Well, there's a difference between apathy and being slackers. Well, okay. So anyways, you can see apathy in schizophrenia, and I'll mention a little bit about that. You can see apathy in major depression, in frontal lobe syndromes, okay? That is disorders that affect the front of your brain. There's, for example, frontotemporal dementia, or it could be a traumatic brain injury, okay? In delirium, okay? In most dementias, I already mentioned Alzheimer's disease, Huntington's disease, Korsakoff's is a type of dementia seen with alcohol, and in certain strokes. Okay, so it's seen in a lot of different kinds of settings. So let's talk about this gentleman again. So he has schizophrenia. Okay, that's his psychiatric disorder. So we just mentioned apathy can occur in schizophrenia. So he's had schizophrenia since his 30s. At least that's, he probably had it even earlier, but that's the best I can obtain from his history. In 2008, when I first saw him, he was severely paranoid. He was very psychotic. He had paranoid ideas about caregivers. He was refusing medical tests because he thought the technicians would kill him, such as if someone tried to do an MRI. He refused his medications. He was very religious. He wouldn't stop praying and would constantly be talking about God. I mean, where that would be all he would do. And at times, he would even, and when he was in the hospital, he would try to touch the female nursing staff. He could be yelling at night because he was responding to voices that he was hearing. And he would be accusing his wife of cheating on him with other men and poisoning his food, and therefore he would not eat it. He was treated eventually with a medication called clozapine, which is an antipsychotic, and all of these symptoms mostly resolved. I mean, they're pretty much all gone. So, I am sure all of you are about to shout at me and tell me, so, this isn't anything to do with Parkinson's disease. He has schizophrenia. You just told me schizophrenia also has apathy. So how can you come here and give me a talk about apathy and show me a case of schizophrenia? Okay? Good question that you asked. So, well, you got an argument to make. Schizophrenia has positive symptoms. These are called hallucinations, delusions, disorganized thinking, disorganized behavior, but it has also negative symptoms, which can look very much like apathy, and may even be apathy in some situations: social withdrawal, lack of interest, lack of emotion, loss of motivation, and neglecting your self-care. However, with our gentleman here, he had primarily positive symptoms of schizophrenia, not so many negative symptoms. You just kind of saw the symptoms he had when he presented in 2008. And the apathy symptoms that he had came back by much later, after his Parkinson's disease started to really get worse, actually by the time he ended up in a wheelchair. So the sequence in time would make me argue with you that no, this is not due to schizophrenia. His apathy was actually due to Parkinson's disease. But, you know, this is a case that's hard to sort out. Okay. So the other thing you could say to me, and I don't have a slide, but there are medications that can cause you to look like you have apathy. In particular, the type of medications I prescribe to patients, such as antipsychotic medicines. They can make you have a masked face. If I give you a drug called haloperidol, you might be walking very slow. You could actually be looking almost like Muhammad Ali does today, you know, where you're shaking, you have Parkinson's symptoms, and you are not motivated because of the medication. So the next thing you want to ask me is, so, Dr. Cohn, you give people with schizophrenia these drugs that cause them to have Parkinson's symptoms, and they can even make them look like they have apathy. So why doesn't this gentleman have drug-induced Parkinson's disease and apathy? So, point well taken. Okay? So, as I mentioned, most antipsychotics, many of them, except for a few, can cause Parkinson's symptoms. This patient actually had been over the years on such medications and had developed worsening Parkinson's symptoms. He was switched to a medicine called clozapine, which does not really cause many Parkinson's symptoms. That's one of the reasons it's used often in psychotic events in Parkinson's disease. And just as an aside, it is considered also one of the best drugs to treat negative symptoms of schizophrenia, although negative symptoms of schizophrenia is hard to treat. So we have someone who's actually taking a medication that probably makes it less likely that his apathy symptoms are drug-induced. Okay. So when does apathy occur? Apathy is present actually in any stage of Parkinson's disease. Apathy can occur whether you are treated or untreated. This gentleman that we're talking about is treated. Okay? I mean, whether you think he's well treated is another question, but he's in treatment. I'm not responsible for his Parkinson's treatment, by the way, just so you know that. Apathy is associated with frontal lobe dysfunction. Now, what does the front of your brain do? Your front of your brain controls your ability to organize and plan, okay, what we call executive function. That is what allows us to decide to, you know, that helps us with motivation and how to do things. And so if that part is injured, you become unmotivated. Let me give you actually an example, a bad example from the history of psychiatry, from One Flew Over the Cuckoo's Nest, actually. When people were out of control in the 40s, 50s, we didn't have medicines. What did psychiatrists sometimes do with people who were really unable to be treated? They destroyed the front of their brain. They did what's called a frontal lobotomy to make the person become apathetic. So that's where, you know, so it is the front of the brain for the most part, although it's a lot more complicated and other parts of the brain are involved, that, you know, helps with motivation. Apathy is also more common in individuals with Parkinson's disease who seem to be fatigued or have symptoms of fatigue, which was another. Okay, I think I mistyped here. Yeah. Yeah. The other characteristic of apathy is the patients will report their symptoms before the caregivers will. Okay. So apathy is associated also with dopamine dysfunction, but at the same time, it cannot be considered entirely a dopamine-dependent syndrome. One, it also occurs in people who don't have Parkinson's disease, of course, and not all Parkinson's disease patients develop apathy. The dopamine system is also involved in the reward process, sort of the opposite of apathy. So you have individuals who take Parkinson's medicines and all of a sudden they're gambling too much, for example. Okay, they're doing the opposite. Okay, so there's a balance here between apathy and other aspects of the dopamine system. How frequent is apathy? Well, these are based on clinical studies of individuals with Parkinson's disease, so the range is wide from study to study. So some studies have it as low as 13.9%, other studies have it as high as 60%. And it also depends on whether the sample of patients that are looked at are early stage, late stage, and whether or not they have dementia. As I mentioned, dementia itself can result in apathy. Others who have looked at this have suggested that those who have stable Parkinson's disease, maybe it's about 15%. Those who have fluctuating disease, it's about 30%. And those who have dementia, it is 56%, as an example of the range. Apathy is also much higher in those who are elderly, over the age of 65, and seems to be higher in those who have low education. Apathy also does not necessarily seem to be related to whether or not, or how severe your motor symptoms are, or whether your motor symptoms are worsening. So the apathy does not necessarily worsen faster or as fast or equal to the motor symptoms. They're somewhat independent. Now the big issue is, well, how does it differ from depression? It can certainly be mistaken for depression. I mean, a lot of their symptoms overlap. Both have lack of interest. The criteria to even have a diagnosis of major depression, you have to have a depressed mood or marked diminished interest or pleasure. That last half sounds like apathy. Depression, therefore, includes symptoms of apathy, and certainly apathy includes symptoms of depression. However, apathy can occur without the presence of depression. So, how prevalent is depression in Parkinson's disease? You're going to hear more about this from another speaker, but it can ranges between 13 to 22%. But apathy is not depression. It is actually an independent clinical construct. Apathy and not depression accounts for deficits in implementing executive cognitive strategies. So, in other words, getting back to the things that this front of the brain here does, in depression, well, you might not be able to do things because you're just not paying attention and you just don't feel like it, but not because you're not able to do it. In apathy, you're not able to do it because this doesn't work properly. And with apathy, your inability to plan and do executive functioning, okay, and organize, for example, it may be actually evidence of early cognitive dysfunction, that MCI you heard about earlier today. So here, I took one of the studies that looked at this, and you can see what the overlap is. So in this population of individuals with Parkinson's disease, 1/3 or 35% of those individuals had neither apathy nor depression. The other third, 36.9%, had both apathy and depression. And then there was a group who only had apathy, but not depression. That was 23%. And another group who only had depression, which was a small group of 4.4%. So there's evidence here that this can certainly be broken out. So now let's go back to our individual that we're talking about, our case. So let's talk about depression. Well, why don't I think he has depression? You know, people with schizophrenia certainly can have episodes of depression. Just because they have schizophrenia doesn't mean they can't get depressed. So why isn't this gentleman's symptoms of apathy depression? How do I know that? Well, my answer to you is, well, okay, I'll admit he's had one episode of depression in his life that I know of, okay? There's no evidence he's ever had an episode of depression before. He's actually never been hospitalized for depression. Somewhere after 2008, he did need to be treated with an antidepressant called citalopram. And we have periodically done the geriatric depression scale on him, and the most that he ever scores is a 1. And the item that he consistently scores a 1 on is that he prefers to stay home than going out. That sounds like apathy almost, okay? This has been consistent throughout. So even though he's in a wheelchair, doesn't do anything, and he says, and you saw that in an earlier slide, he says, I'm so-so. He doesn't say I'm depressed. He doesn't say I want to die. He doesn't say I want to kill myself. You know, he's eating fine. You know, he's sleeping fine. You know, there's no evidence he has what we call vegetative symptoms. Now, there's a number of investigators that break down apathy into several different types. One of them is way too complicated for me to even understand or explain, because I can't understand it. The one that makes sense to me is something simple like this, that they break it down into the dopaminergic type, okay, which responds to dopaminergic agonists, okay, and can be seen in some patients who undergo deep brain stimulation when they are taken off of their medications. And then there's the other type called the late stage that don't respond to the Parkinson medications and might even suggest that it's a precursor to developing dementia. So, Dr. Cohn, what type of apathy do you think he has? Well, Does he have late stage? That's what I think so. First of all, his apathy appeared only when his Parkinson's disease had progressed to the point he could not walk. Didn't come on early. And secondly, it hasn't ever mattered whether or not he's taken dopaminergic drugs, his Parkinson's drugs. He still has had the same apathy. It hasn't ever changed. Okay. So there's another construct that kind of goes along with apathy, and that is called anhedonia. Anhedonia is also seen in depression, by the way, and it is simply the loss of pleasure. And there's two explanations for loss of pleasure, that are looked at. One is that I don't get pleasure when let's say, something happens, okay? Like, let's say, I give you a present, you don't care. I don't get pleasure about that, okay? It doesn't look like that's, and then the other one is that, you tell, I'm planning to go to Disney World. Something in the future that's going to give me enjoyment. And I don't really care about that, okay? So that's the anticipatory one I just talked about. The other one is this consummatory one. So anyways, it does appear that apathy in Parkinson's disease is actually associated with anticipatory pleasure. The one where, you might want to think about your birthday coming up or your wedding anniversary or something like that, or going that, your grandchild is going to graduate. Okay, that'd be, on the other hand, other people have said, well, this is not anything to do with apathy because, this issue of loss and pleasure is more of an issue with depression. So that's an issue of debate. So the next question that people have looked at is the relationship of apathy and worsening of Parkinson's disease. So people whose Parkinson's disease is getting worse, it appears that apathy and attention and memory are the most newest symptoms, new onset symptoms. Apathy is associated with worsening cognition, and in particular, as I mentioned already a number of times, your ability to plan and organize, your executive functioning. Apathy increases your risk of developing dementia, whether or not you have depression. So it's independent of depression on the risk of developing dementia. And it could even be predictive of developing dementia. Apathy decreases quality of life. It is associated with worsening decision making, okay, which is sort of we've already alluded to, and it also may increase morbidity and mortality. Apathy comes about before dementia in Parkinson's disease. As I've mentioned again, it's related to frontal cognitive impairment, so what's going on in the front of your brain. It is involved with the dopamine system in terms of reward and motivation. And it can be seen in people who even are optimally treated with their Parkinson's medicines, which we've already mentioned. It is seen more often in individuals who are declining cognitively, and it may be associated also with deficits in cholinergic neurotransmitters. What does that mean? Cholinergic neurotransmitters are one of the bases of the theory of Alzheimer's disease. Alzheimer's drugs, which are called acetylcholinesterase inhibitors, the biggest class of them, like Aricept, for example, or Exelon that you may have heard of. Those are medications that add acetylcholine to the brain, okay, that try to counteract the deficits in cholinergic neurotransmitters. So now let's go back to our gentleman here who has Parkinson's disease and apathy. Now the question is, well, does this person have cognitive impairment? And if he does, how do I know that his cognitive impairment is due to Parkinson's disease, schizophrenia, or dementia? Okay? Or even or apathy. Okay? First of all, 10 to 78% of persons with Parkinson's disease develop dementia. Schizophrenia, you're going to say, well, doesn't that cause dementia? I mean, Kraepelin, the famous psychiatrist from the 1940s, called it dementia praecox. Okay? No. Schizophrenia does not cause dementia, but it does have cognitive problems, such as problems making sense of information, difficulty in paying attention, and nonspecific memory problems. Okay? So this gentleman has cognitive problems that which began after he developed apathy. Okay? And I'm going to show you the evidence of that. On 5/28/2008, his mini mental state exam score was 28, was fairly normal. He had Parkinson's disease back then already for a long time. He already had schizophrenia. Okay? Just now, in July of this year, he had dropped 7 points in 5 years to 21. Now, is this due to apathy? Is this due to Parkinson's disease? We know it's not schizophrenia. Is he just starting to develop Alzheimer's disease, maybe? Well, in honest, I don't know the answer. Okay? One can't know that answer by looking at one person in the office, because the only way they know this is when they do research with a whole bunch of people, so I can't tell that with just a single person, an individual, why they're losing their memory, okay, and what it's due to. Now, this is an area of controversy, so I'm going to talk about treatments. And there isn't much information at all on treatment about apathy in Parkinson's disease. There's very few studies. The studies that do exist are very small, and very few of them even have control groups. And this was very, enlightening to me, because I did not even realize this. Deep brain stimulation, which actually at times seems to make apathy worse. Now, the thought here is it may not really be the deep brain stimulation itself, but the removal of Parkinson drugs. The most common type of antidepressant in the world are serotonin reuptake inhibitors. So we're talking about Prozac, Celexa, Zoloft, Paxil, Lexapro. All of those are serotonin reuptake inhibitors. Those medicines apparently make apathy in Parkinson's disease worse. These are the most commonly used drugs to treat depression. Interestingly enough, there's no evidence that other classes of antidepressants do that. So, what treatments do seem to help? Well, dopaminergic drugs seem to help, especially those who have apathy at earlier stages. But again, there's no real good studies of this. Stimulants, and maybe help. I could not find, I saw mention of this in the literature. I did not find one study. However, in the treatment of Alzheimer's disease, this is the most common way to treat apathy. As a matter of fact, just now in I think it was in JAMA, or the American Journal of Psychiatry, actually, there was a placebo-controlled study that was fairly of reasonable size, showing that methylphenidate, Ritalin, which is a stimulant, helped treat apathy in Alzheimer's disease. We know, actually, in Alzheimer's disease research that, for example, Provigil, which is used to keep people alert from sleep apnea, doesn't work, even though that's a stimulant. Okay? That's been studied and not shown to work in that disorder. Acetylcholinesterase inhibitors. These are the Alzheimer's drugs I mentioned earlier. Well, there's some thought that that may be helpful, mainly by treating the cognitive deficits and slowing down the cognitive deficits. Acetylcholinesterase inhibitors, the Alzheimer's drugs, do not cure, do not stop the cognitive disorder. It simply slows it down. Okay. Now, there are people who also say that the brain stimulation may help. Okay, now you've heard from both ends. And then there are non-medication or non-somatic treatments also that should be considered, such as psychotherapy, occupational therapy, and one study showing that exercise was helpful. So let's turn back to our individual here who has with Parkinson's disease and apathy. So, Dr. Cohn, you're the treating psychiatrist. So what are his medications? Are you doing anything to help him with his apathy? Okay, or you're making it worse? Okay, so let's find out. Okay, so here's his neurological and psychiatric medications. He's on clozapine. Clozapine is an antipsychotic that is anticholinergic. Okay, what does that mean? That means it does the opposite of what those Alzheimer's drugs do. It takes away acetylcholine from the brain. It is interfering with the cholinergic system. In essence, it could make memory worse. Okay, so obviously that's one of the things we talked about earlier that could be one of the things related to apathy. Oh, Dr. Cohn, you're giving him citalopram. Didn't you just tell me about 10 seconds ago that that's a serotonin reuptake inhibitor? Doesn't that make apathy worse? Dr. Cohn, you're not doing too good. Okay. Then, well, you have him on Sinemet at least. That's a dopaminergic drug. Good for you. Okay, so he's on some medicines that are helpful, some that aren't so good. Okay. I've never thought about putting him on a stimulant, mainly because, you know, I'm very concerned that he may become psychotic. Okay, and it's too unpredictable in this situation. I could put him on an acetylcholinesterase inhibitor. I think the main reason I haven't, which you'll see in a little minute, is I'm not sure they can really afford it. They have to deal with Medicare Part D. You all know what that means. Called the donut hole. Okay. Caregiver burden. So this is in general. Most of you know this. Caregiver burden is increased when the individual Parkinson's disease has more disability, more severity of illness, more cognitive impairment, longer their illness has been, and more depression. Well, what about apathy? What does that do to caregiver burden? A lot. Apathy has greater caregiver burden than is seen than in those individuals with Parkinson's disease who do not have apathy. In particular, those who have attention problems have more caregiver burden. So apathy with attention is even worse. And then, amazingly enough, I was shocked by this number. In statistics, we call this the variance, or this is the percent of how much a certain problem explains everything. So caregiver burden, in this one study, apathy explained half of all the caregiver burden. That's amazing. I mean, that included depression, included all sorts of other things. Half was explained by apathy. So, now, how does this relate to our patient here, our gentleman who has Parkinson's disease? Well, he's in a wheelchair due to Parkinson's disease. Certainly that must increase caregiver burden. He has chronic schizophrenia on top of having Parkinson's disease. However, the good thing is nowadays he takes his medications without an issue. He's compliant, unlike in 2008. His wife has chronic mental illness with her own behavioral problems, but she does also take her medicines faithfully. The couple lives on Social Security and make too much on Social Security to get Medicaid. So what they, it makes a difference. If you're poor and on Medicaid, you don't fall between the middle. Okay? His wife, however, was not able to manage him at home when he was psychotic, and he had to go to a nursing home for about a year. But, he ended up getting his hallucinations and delusions controlled in the nursing home by coming to our office regularly. Once he was no longer thinking that she was poisoning him and would eat her food, and realized that she was a faithful wife, she felt she could manage his Parkinson's disease even though he had apathy, even though he was in a wheelchair, and brought him home. She had very little support and still does to this day. She has some CNA hours that the state will provide her with her, and she has a Hoyer lift to get him in and out of bed. They don't have children who live at home. She has provided him excellent care. When she comes to see me for her own things, mainly she talks about her concern for his problems. You ask her how she's doing, even though she's overwhelmed. The only thing she'll complain about herself is that my medicines make her fat. Okay, so I think she's a great example of a committed and resilient caregiver. Thank you.
Well, that's a brilliant overview of what you can see as a very complicated topic that we do not yet know enough about in terms of management, but something we're paying more attention to.